Good evening, and welcome to the July 9th meeting of the Board of Directors of the Washington Hospital. I'd invite you all to stand and join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, if you'd take the roll for us.
Yes. Director Stewart,
Present.
Director Wallace,
Present.
Director Nicholson,
Present.
Director Danielson,
Present.
Director Eapen.
Present.
Thank you, Catherine. We'll now move immediately to our education session. Nancy, if you could introduce the first item there.
The first item on our agenda is to introduce the Medical Director of our stroke program, Dr. Ash Jain, and his partner in developing this program, Doug Van Houten, RN, who's a very important part of the development and the ongoing management of this program. Thought we'd ask Doug to come forward. He has an announcement to make. Or you want to introduce your guest? Okay, all right. You can go wherever you want. That's a good place because,
Right.
yeah.
Well, thank you very much, Nancy. Very happy to be here tonight and talk about the stroke program for a minute. We're always trying to do as well as we can on all of the various measures for stroke, and the American Heart Association acknowledges these, and we are proud to get recognition from the American Heart Association every year. And I'd like to introduce Joanne Pineda from the American Heart Association.
Thank you, Doug, and good evening. My name is Joanne Pineda, and I'm the Senior Program Director for Get With the Guidelines for the American Heart American Stroke Association. And on behalf of the American Heart American Stroke Association, I'd like to congratulate Washington Hospital Healthcare System for achieving the Gold Plus and Target Stroke Honor Roll Award for implementing Get With the Guidelines stroke in the hospital and within the community. There's several steps required into achieving this award. One is putting together a multidisciplinary team. You've identified Dr. Jain here as your physician champion and Doug as your nurse champion, but I'd also like to thank or recognize the emergency room staff and other neurologists involved in the whole process as well. Additionally, Washington Hospital will be recognized in an ad coming at the end of the month in the America's Best Hospital issue of U.S. News and World Report, listing out this distinguished award. And it's with great pleasure to present the Get With the Guidelines Stroke Gold Plus Target Stroke Honor Roll Award to Washington Hospital.
Well, I'd like to say a few words, if that's okay, Nancy.
Yes, please.
Good evening. It's almost, I think, the 7th year we are into now with the stroke program, and it is done very well. But this credit goes to, believe it or not, 14 departments that are in the hospital. It is not a one-man show or two-man show. It involves ER, radiology, lab, people that don't even show their faces to the patient. So there's a lot that happens in the background. And I would like to congratulate all of them to make this program successful, though they don't show their faces to the patients or to any of the community. So I think if we can write something up and congratulate them, that'll be very nice. Thank you. Thank you.
Brief appreciation award that I wanted to present to Doug Van Houten for his dedication and service to the American Heart Association. So on behalf again of the American Heart American Stroke Association, I'd like to present this appreciation award.
Thank you very much. I really appreciate this. This is a lovely award. I'll put it in my office tomorrow. Thanks very much. And I've got to say, I could not do my job or get an award like this without the help of the whole stroke team, and particularly my stroke nurses. And I have two in the audience here, if they'll please stand. Denise Lynch and Tasha Narivas. And they're just wonderful stroke nurses, and I couldn't be any happier with them. So thank you very much.
Thanks to both of you. It's a very, very nice thing to see. Just this last week, I saw a person who had been a patient with a stroke. And they were amazed at how coming into the hospital immediately they said I was the most popular person there. It is the idea, and we appreciate all the work you're doing there. Thank you very much.
I'd just like to add that when I'm out and about in the community, the nicest compliments I get about our hospital are about the stroke team, and in particular about our stroke nurses. They deserve a lot of credit for the strength of the program we have.
It's a wonderful program. I don't have any desire to ever be there, though. Nancy, if you'd introduce the next
Yes.
item.
The next subject we're going to cover this evening is about the Medical Injury Compensation Reform Act, which is known by its acronym MICRA. We have three people here to present to you tonight. I'll go through their bios quickly, and then they'll begin the program. We'll start with Dr. Albert Brooks. He's our Chief of Medical Services here at the hospital. He came to us from Alta Bates Hospital in Berkeley, where he'd been chairman of the OB department and president of their medical staff, and then served on the board of trustees of their hospital for 12 years. He was born and raised in New York City. He attended Albert Einstein College of Medicine, where he completed his residency in OBGYN. He served as the OB hospitalist director here at Washington Hospital in 2004 and helped get that program off to a successful start. Currently, he streamlines our credentials, quality improvement, bylaws, policies and procedures, and rules and regulations. He also serves as a liaison capacity with the medical staff leaders and this administration. He's president of Washington Township Medical Group and is a member of the board of Washington Township Medical Foundation. Also speaking tonight is Donald Pipkin. You've seen him previously present the economic impact report to the board in the last year. He's been with Washington since 2006 and is the Assistant Chief of Strategic Management. He received his Bachelor of Arts degree from Claremont McKenna College, where he majored in environment, economics, and politics with a leadership sequence, and received his Master's of Healthcare Administration degree from the University of Washington in Seattle. Also speaking tonight is Chris Brown. He's a graduate of the University of Oregon and has been a healthcare communicator for more than 20 years. He currently serves as Washington Hospital's Director of Media Relations and Integrated Marketing. In that role, he oversees media relations and serves as the hospital's Public Information Officer. He also oversees marketing for several healthcare system entities, manages the hospital's web and social media presence, as well as InHealth, a Washington Hospital channel that this very same board meeting appears on. With that, I'll turn the program over.
Thank you, Nancy. This evening we'll be discussing the Medical Injury Compensation Reform Act, or MICRA, and a state initiative related to MICRA, which will be on the November ballot this year. So tonight I'll be joined by Dr. Brooks and Chris Brown to provide you background on the initiative process, background on MICRA, and the potential impacts that Proposition 46 may have on physicians and patients, and finally, some information on the proponents and opposition of the initiative and how citizens and organizations can get involved. So just over 100 years ago, California became the 10th state to adopt the initiative process. The initiative process is a tool for citizens to adopt laws and constitutional amendments without the support of the governor or legislature. So the legislature put a package of constitutional amendments on the ballot that placed more control of California politics in the hands of the people. The package included
the ability to recall elected officials, the right to repeal laws by referendum, and the ability to enact state laws by initiative. So the initiative really is the power of the people of California to propose statutes and propose amendments to the California Constitution. Generally, any matter that is a proper subject of legislation can become an initiative measure. However, no initiative measure addressing more than one subject area may be submitted to the voters or have any effect. An initiative measure is placed on the ballot after its proponents successfully satisfy the requirements set by law. The initiative process is comprised of 7 major steps, which I'll review at a high level. These include writing the text of the initiative, requesting the title and summary from the Attorney General, circulating petitions and gathering signatures, verification of those signatures, and ultimately qualification and potentially approval of the initiative. So the first step in the process for qualifying an initiative measure is to write the text of the proposed law. The initiative measure's proponents may obtain assistance from the Office of the Legislative Counsel in drafting the language of the proposed law. Proponents must obtain the signatures of 25 or more electors on a request for a draft of the proposed law. And then proponents must present the idea for the law to the Legislative Council. If the Legislative Council determines that there is a reasonable probability the initiative measure will eventually be submitted to the voters, the Legislative Council will then draft the official proposed law. Proponents may also seek the assistance of their own private counsel to draft the proposed law, or they may choose to write the text of the law themselves. Once the proposed initiative measure has been written, the proponents must submit a draft of the initiative measure to the Attorney General with a written request that a circulating title and summary of the chief purpose and points of the initiative measure be prepared. At the time of submitting the draft to the Attorney General, the proponents must pay a fee of $200, and upon payment of the fee and the request, the Attorney General will prepare a circulating title and summary, which will be the official summary of the initiative measure. If a fiscal estimate or opinion is needed, the Attorney General shall include either the estimate of the amount of any increase or decrease in revenues or costs to the state or local government, or an opinion as to whether or not a substantial net change in state or local finances would result. Step 3 is the format of the petitions. These are specified by law. They include certain formatting requirements such as typeface size, specific language required by the Secretary of State, and then some specified space for signatures as well. In step 4, circulating petitions and gathering signatures. So proponents are allowed 150 days from the official summary date to circulate petitions and gather signatures, and the initiatives must qualify at least 131 days before the next statewide election. Petitions must be signed by registered voters in his or her county of registration, and the required number of signatures varies based on the type of the initiative submitted. So initiative statutes such as Proposition 46 or referendums require more than 5% of the total votes cast for governor in the last gubernatorial election. And for constitutional amendments, that requirement is more than 8% of the votes cast. So for the upcoming election cycle, the signature requirements are for initiative statutes and referendums, just under 505,000 signatures, and for constitutional amendments, just over 807,000 signatures. So step 5 and 6, if the number of signatures, once the requisite number of signatures has been collected, they're filed with the county election officials. And then county election officials count the number of signatures. If the number of signatures submitted and tabulated in the raw count by county election officials does not meet the minimum requirements, the initiative fails to qualify. Then random sample verification is conducted, and that's a process by which there's a random sample of 500 signatures, or 3% of signatures filed for each county. Whichever is greater is then conducted. In the final step, the statewide number of valid signatures is determined. So upon completion of the random sample process, the Secretary of State applies a formula to determine the statewide total of valid signatures. If the total number of valid signatures is less than 95% of the required minimum, the initiative fails to qualify. If the total number of valid signatures is more than 110% of the required minimum, the initiative is deemed to be qualified. If the total number is between 95 and 110%, county election officials actually need to count every signature on that petition. If the initiative does qualify, the Secretary of State notifies the proponents and county election officials of the qualification. The Attorney General, State Senate, and Assembly are also notified, and then each House holds a joint public hearing on the subject of the initiative. And then if it's approved, it will receive a majority of the votes on Election Day. So although any of us can submit an initiative to qualify for the ballot by spending $200, the reality behind the cost to qualify the measure are a very different story. To gather the needed signatures, it is very common for groups to pay between $1 and $2 million. And as I mentioned, if you are able to gather the required number of signatures and those signatures are validated, you next need to run a campaign. So one quick example on the levels of cost to run a campaign for the initiative is to look at Proposition 46. The initiative being run by the trial attorneys is attempting to increase the medical malpractice judgment awards. It's estimated that both proponents and opponents will spend in excess of $50 million for the campaign for this proposition. Another good stat can be seen by looking at how many initiatives have been filed to receive a title and summary. So as of 2013, 1,767 initiatives received a title and summary. Over 1,300 of those, or 74%, failed to qualify for the ballot. 360 measures over the last 100 years or so have been placed on California ballots, of which 122, or 34%, have been approved by voters. Sample of some initiatives: Proposition 98, which mandates funding for K-12 education; Proposition 13, which limits property taxes; daylight savings times was passed through an initiative, and the death penalty was passed through an initiative in 1972. Initiatives do have an impact on the California state budget. So Proposition 98, which was passed in 1988 to mandate funding for K-12 education, ties up a large portion of California's budget. In the budget just signed this year, Proposition 98 amounts to about $44 billion, which represents about 42% of the state budget. It's estimated that about another 2 to 3% of the California budget is dictated by the results of propositions. And this figure does not include debt service for bonds issued as a result of state initiatives. So about 45% of the state budget is dictated by propositions passed through the initiative process. And with that, I'll hand the presentation over to Dr. Brooks.
Thanks, Donald. So now we have Proposition 46. It's made the ballot. It's going to be there on November 4th. By the way, if on November 5th, many of the elements go into effect of Proposition 46, and there's several elements that really frighten me and frighten all of us in healthcare because of their potential impact. Originally, this proposition had the title of the Troy and Alana Pack Patient Safety Act. This case does not involve a physician on drugs, but it involves an individual who was driving a car and was under the influence of alcohol and codeine. The particular individual passed out and hit a family who were out for a walk. Unfortunately, the incident resulted in the death of Mr. Pack's 2 children, as well as the twins his wife was pregnant with. So they changed the title to the following words: Prop 46 is now listed on the ballot as the Drug and Alcohol Testing of Doctors Medical Negligence Lawsuits Initiative Statute. And here's the official summary, and just bear with me, I'd like to read it to you because it's really, it's a mix of things. Requires drug and alcohol testing of doctors and reporting of positive tests to the California Medical Board. Requires the board to suspend the doctor pending investigation of positive tests and take disciplinary action if the doctor was impaired while on duty. It requires doctors to report any other doctor suspected of drug or alcohol impairment or medical negligence. It requires healthcare practitioners to consult state prescription drug history databases before prescribing certain controlled substances. And lastly, it increases the $250,000 cap on non-economic damages, so-called pain and suffering, in medical negligence lawsuits to account for inflation. Basically, this law was put together by bringing certain elements together. And there was, the group that supports this decided they would do focus groups, and in particular, a focus group in Pasadena noted that after finding through the focus group that physician drug testing polled favorably, the provisions requiring random testing were included in the initiative. By the way, this subject has been discussed previously about drug testing for doctors, similar to drug testing for pilots, etc. So what it states is physicians who have cared for or prescribed drugs for a patient involved in an adverse event must be tested within 24 hours. That the physician must be tested. And failure to be tested deems the physician negligent. So there's a presumption of guilt in this particular proposition. Additionally, physicians are mandated to consult the Cures database, which is not a very well-worked system. In fact, many of our doctors use the Cures database. Right now, there are over 100 million entries in the Cures database in California. Cures stands for Controlled Substances Utilization Review Evaluation System. And right now, about 60,000 physicians and pharmacists use the Cures database. But many of us find when we use the database, it freezes, it locks you out, it doesn't know your password. Even the state has realized that the Cures database does not work well. In that database are prescriptions for Schedule II and Schedule III drugs, and many of those are non-narcotic drugs. So Cures doesn't work well, will not be able to handle huge increases in volume. It pits the patient's needs against the law because you won't be able to prescribe narcotics for the most innocent of reasons if you haven't consulted the Cures database. And Prop 46 does not provide any funding to improve the Cures database. Now, with regard to non-economic damages, this ruling would increase the cap on non-economic damages, and it'll increase healthcare costs dramatically. A legislative analyst projects that passage of Prop 46 would cost the state and local governments hundreds of millions of dollars annually, and would increase healthcare costs for everyone in this state by $9.9 billion annually. If the cap were only increased to $500,000, those numbers apply. Imagine what's going to happen if it's increased to $1.1 million, which is 4 times, the amount. Higher costs are going to translate into reduced access to care, especially at clinics. Most of our clinics, especially who serve the underserved, are not going to be able to increase by 4 the costs of the physicians' malpractice who care for the patients in the clinics. Doctors in their offices are not going to be able to afford that, and they're going to leave the state in droves. And it'll also increase litigation because now attorneys will be able to take cases that are borderline and feel that they can now bring that into the system because they see the benefit of the higher amount of money that's potentially awarded to them. We had a similar crisis back in 1975, and many of you may remember that MICRA was born out of that. The Medical Injury Compensation Reform Act of 1975 was born, in fact, to deal with the crisis that was going on at that time. The frequency of malpractice lawsuits had doubled. There were $1 million awards increased 5-fold, and physicians had to dramatically increase their policy limits. By the year of 1975, every malpractice insurer was insolvent. And the ACCMA's group program was canceled. That's the Alameda Contra Costa Medical Association. And physicians were offered a 90-day policy at a rate increase of 384%. Only urgent and emergency care was available. A massive media campaign combined with intense lobbying forced the governor to call a special session of the legislature, and MICRA was adopted by the end of that. And he's now still the governor who called that special session. So MICRA is good public policy as we currently have it. It governs all malpractice litigation, including arbitrations, regardless of whether you are insured or self-insured. It provides unlimited payment of all present and future economic damages, medical costs, future income. And as a result, malpractice awards have increased over inflation up to 4 times since 1975, and this is an argument that we can say. Now, it hasn't kept the total amount of money down, but at the same time, it's been reasonable to increase the amount 4 times. And again, I'd like to emphasize in the current MICRA law, there is no cap on punitive damages for intentional wrongdoing. It limits the plaintiff's attorney's contingency fees from half of the award to significantly less, and it dramatically increases the amount the patient receives. So when you hear criticism of MICRA, this opposes that. Periodic future payments can be made for awards over $50,000. That's another last point that I would make, to say that it organizes how patients are going to be paid over time as opposed to lump sum payments. So economic losses can be calculated with great certainty under MICRA. Non-economic damages, they are the prize, so to speak, that is what is going for in Prop 46, because if you change that, obviously trial lawyers have a greater incentive to try a case with questionable merit and hold out longer in settlement negotiations. You are going to have, if MICRA goes away, greater frequency in litigation and higher awards, making the impact of an increase in the cap exponential. The other point, and I think it's really an extremely important one for those of us in healthcare, higher malpractice costs take away precious resources for healthcare. And those most acutely affected are going to be uninsured, low-income patients which come to Washington Hospital every day who receive care. The community clinics here, Planned Parenthood, the county health systems, and they are all part of a coalition of 1,000 organizations who are standing up to defend MICRA. High-risk services, emergency services, obstetrical services, neurosurgery, they have the greatest exposure. And rural areas will be most acutely affected, I think, and struggling physicians may have to close their doors, as happened in 1975, or leave the state. One example of tort reform that we can see in other states is Texas passed a tort reform in 2003, adding more than 14,000 physicians and increased per capita numbers of physicians, including specialists and rural physicians. So that state did the right thing. New York, on the other hand, has no reforms in their malpractice. There are currently 19 counties in New York without an OBGYN. There are 22 counties in New York State without an internist. And there are 15 counties without a surgical specialist. I have friends who practice in New York. They pay $120,000 a year in malpractice. And it's just an untenable situation. Just to give you examples, right now in California, this slide shows you what OBGYNs pay. They pay around OBGYNs in our state pay around $35,000. I think in the Los Angeles area, that's up to $61,000. And if MICRA goes away, OBGYNs will pay $162,000. That's based on the average of 5 states in the United States, what the fees would happen. And then the other bar graphs show you what it is like for a general surgeon, could be as much as $120,000 a year. And for an internal medicine doctor, $34,000 as a premium if MICRA goes away and Prop 46 is successful. So the key issues in the campaign, the trial lawyers' argument of patient safety through physician drug testing loses support when access to care and increased cost concerns are raised. The state database of everyone's drug prescription information has also become a privacy issue in the wake of Target's problems, which were the result of malicious hacking. That database can be accessed by all government employees, and your private information could be at risk. And Consumer Watchdog did point out that they added those two elements as a ultimate sweetener to getting the malpractice law changed. And it was done after they had talked to a focus group, as I said earlier. Next, Chris Brown. Did I go in the right direction?
Thank you, Dr. Brooks. So I'm just going to talk a little bit about the support and opposition and what's at issue with Prop 46. Much of it you've already heard this evening. So who supports it? It's principally supported by the consumer attorneys of California, trial lawyers, and also by Consumer Watchdog, which you heard a little bit about from Dr. Brooks. In fact, Consumer Watchdog is very active. They just today sued Blue Cross for a variety of allegations related to enrollment in the Affordable Care Act. Now, who opposes it? And I'm going to warn you, this is a fast scroll here because I just wanted to kind of give you an idea of the diverse opposition. So, the opposition, as you can see, it goes by fast. It's hundreds of groups of doctors, nurses, community health clinics, hospitals, family planning organizations, local leaders, public safety officials, businesses, labor unions, and many others. As you can see, the list goes on. And quite frankly, there's several groups in here that are often on opposite sides that actually have come together to oppose the measure. So just to sum up here, according to California's independent legislative analyst, Prop 46 will increase healthcare costs across all sectors by $9.9 billion annually. What this translates to for an average family of four is about an additional $1,000 in healthcare costs annually. Also, according to the independent legislative analyst, changes in MICRA would increase state and local government healthcare costs by hundreds of millions of dollars. And when Dr. Brooks referred to limited access, closing of clinics for the underserved, these are the choices that state and local government are going to have to make based on having to pay more to keep one clinic open because of the MICRA reform. Also, according to the California Medical Association, Prop 46 would reduce access and jeopardize people's ability to see their trusted doctor. Many doctors are simply going to move on to another state. They are going to relocate so that they can actually do business and practice medicine in a less litigious state, one that where liability costs are less. And obviously that's going to upset many people who, quite frankly, have a lot of trust in the doctors they see. And additionally, that also will have an effect on the number of clinics that are open to serve the underserved. And also, as you heard earlier, Prop 46 will threaten the privacy of personal prescription drug information. I don't need to go on about all of the hacking and so forth that we've seen in the news, the information that has been sucked up by government agencies, including medical records, but obviously the personal prescription drug information contained in this very vulnerable database, which has no additional funding allocated to it through Prop 46, is a problem. In fact, the Attorney General has even admitted that it's not ready to take on the demands that would be placed on it if Prop 46 passes. And as Dr. Brooks said, they have to basically turn that on November 5th. There's no provision to improve the database before it actually has the increased demands placed on it. So having said that, and I'd like to invite Donald Pipkin and Dr. Brooks back up here to the podium if you have any questions.
Well, we appreciate all three of your presentations. It's nice to have an update on this at an early stage of the election process. This will be November, clear a long ways from now in some ways. But nevertheless, this is an issue that will impact our entire state. And we appreciate your presentation on that. Thank you all for the research you've done and for bringing that to our attention and to we hope through Channel 78, to the attention of our communities. Ms. Danielson.
I have one question. Would you just repeat, I'm not sure I got the number down correctly, how much you anticipate the trial lawyers to be spending on the campaign? Was it 5 or 500 million?
So the estimates are that both the opponents and supporters of Prop 46 combined will spend in excess of 50. That number right now is ranging
50.
Between 50 and 70, but that's both of them combined.
Okay, thank you.
By way of full disclosure, CMA has committed, I think, $60 million because this is, a struggle that we have to win.
We need to clarify that. That's the California Medical Association.
California Medical Association.
So that would be in opposition, and they've committed $50 million.
Yeah.
Shows
Be
you
in
how-
opposition to the.
Shows you how important they feel it is.
Yeah, it's the thinking, and I'm a member of the ACCMA Council. The thinking when they talk about it at the council meetings is that the trial lawyers have been floating this balloon for about 5 or 10 years, or even longer than that, thinking was it right or a time that they could do this to make this change. And we thought in the beginning, about a year ago, they weren't going to do it. They didn't have enough money. But they've decided to go ahead with it, and obviously they got it on the ballot by adding the prescription drug piece and taking that approach as opposed to just coming out with a single bill for micro reform. They didn't think that polled well when they did their polls.
Any other questions from board members?
Dr. Brooks, I'm really concerned about access to care. And I wonder if CMA or the local medical societies have made an analysis of what they would expect to happen with the physician population. How many physicians will remain in practice? How many will retire? How many will leave the state? How many of the physicians who are training now at our wonderful medical schools here in California, how many of those will elect to continue their training out of state and not be able to provide services here?
Yeah.
Because I think this is the crux of the problem, is that if we make it untenable for physicians to maintain a practice here, patients are going to suffer and lives will be lost.
Nancy?
I was an administrator in training when the medical malpractice crisis in the 70s occurred in this state. I had a friend who was a physician in Fortuna, California, which was a medically underserved rural area, and most of his patients didn't pay him in cash. They would fix his roof or give him some chickens or something like that, and the few who could pay him did not pay him much. He left the state because he could not afford the premiums for delivering babies. He was a family practitioner, and in rural Northern California, that's what you did. You delivered babies, among many other things. And he left the state. He went to Texas and took a job as an emergency room physician. He could not afford his malpractice liability insurance. What I saw in Los Angeles was that the bigger institutions like UCLA, where I was in training, did keep the coverage and were taking patients, but women were coming from over 100 miles away to have their babies at UCLA because their hospitals couldn't afford the malpractice liability. This is massive disruption on a scale that most people don't understand. And people just stop taking care of their patients because they can't afford the liability insurance, and they don't dare take the risk of going bare because it could destroy them financially and their families in a way that they may never recover from. And it's a horrible risk to ask the doctors to take. So many smaller hospitals just stopped those services. Hollywood Presbyterian was maybe, as a hospital I was aware of in Los Angeles, is maybe 2 weeks away from shutting its doors. Because when the doctors stopped working, the patients stopped coming to the hospital. So it is a big deal to, let the lid off the pot and have it become a free-for-all for trial attorneys to do this. I've seen it, and I think it endangers patients. I know it does. I watched it.
The other question I had has to do with the requirement of physicians to query this dysfunctional cures database. And does that apply to any scheduled medication, anything that requires our DEA license to prescribe?
It's all Schedule 2 and 3 narcotics in particular, which has a lot of anti-anxiety drugs, not just narcotics.
Sure.
So if you prescribe something that's just, a sleep medication, you're going to end up having to go to the Cures database before you do the prescription.
Does it apply only to narcotics, or does it apply to other Schedule 2 and Schedule 3 drugs? I can think of
it's
I
other.
can think
It's-
of the pediatric patients, and maybe Dr. Epen can comment upon this, is the medications that are often used in treating the pediatric population are often Schedule 2 and 3 drugs. To my knowledge, my knowledge is quite limited there, but perhaps Dr. Epen could comment upon, if this comes into place, will this impact not just the pain medications, but other drugs involved?
Most of the drugs that are used for hyperactivity and attention deficit disorders are Schedule 2 and 3 drugs.
They're Schedule 2,
And
yeah.
they're all by
So it
public-
applies to all of them, all Schedule 2 and Schedule 3, whether they're a narcotic or not.
So if you got a kid with ADHD and your doc is not able to query the database because it's either not working, it's been hacked, or the lines are down,
You run the risk of violating the law. by
is the
not
doctor
doing
going to do that?
it. The doctor may do it, but this is just crazy. The doctors may say, I'm not going to do that. I can't give you this prescription until I'm able to access the Cures database. So what is that going to do? Delay health care or even stop care?
This is a huge concern.
Oh, it's
I think the public has
tectonic, if you will.
has
say
really
that
got
in
to
an
be
earthquake.
informed about all of the consequences of this legislation, or of this initiative process.
I think it's sad, but I think it's whoever's going to run the best campaign.
Yeah.
And because it is confusing, and many of the people that I've talked to about this subject they simply think that all of the damages are capped at $250,000, and so it's, as you
Yeah.
pointed out, the economic damages are clearly covered, the punitive damages are clearly covered.
Yeah.
Awards are out there for $10, $20 million.
Yeah, those awards are out there.
They're
man.
out there.
You're absolutely right. They're out
Yeah,
there. People
yeah.
are still getting that money.
Right.
So there's this concept of the patients aren't getting
Yeah.
large, rewards. They are awards.
Yeah, of course, yeah.
You also mentioned something about confidentiality. So does HIPAA apply or does it not apply? And where's the confidentiality break at? And how can they feel comfortable with knowing that their medical records are being looked at by other people?
It's exactly the point. And in fact, anybody in a governmental agency can find that data out in the state of California. If they work they can go to the access to database. Now they have to have a password, and obviously they should protect their password, but this opens up a whole can of worms around
That exists
privacy.
now? That exists now?
Yes, it's now. It's as Cures. If you get a chance, you can Google it and see how you can go into it. But you have to have a password, and you have to be an MD or a pharmacist or a government employee. This is the database is up and running. It's there.
And there's
Over 100 million entries in that database right now.
And there's no protections for the patients can a government employee have access to Cures, use that data incorrectly? Is there penalties?
I don't know. I would imagine there are penalties if a HIPAA violation. I've gotten the report as a physician, and I've seen a cures report on the patient, and for some reason they had my name, and they sent it to me. It shouldn't even come to me. And yet, because my name was similar to another doctor with the same last name, it's totally flawed. I've talked to our ER doctors. They go there many times in the ER when they think they have a patient abusing drugs. And they're clicking on it and waiting, it doesn't respond. Well, right now, there's no coercion that they do that. They try to do that to practice good medicine, but it's just totally flawed, and it doesn't work. And people still drug seek in spite of it.
One of the things I worry about is that, with so many issues around names being similar or even identical, you could end up not being able to access the medicine you need because there's no way to tell the difference. And this is a challenge we've had in our own IT system where we've had to put name alerts up when you had the same name.
This is the medical equivalent of the no-fly list.
Yes, it is, because you could get stopped right there and never have access to what it was you needed. And I don't know what kind of access they're providing for people who need to get something corrected. It could take forever to do that.
I wonder what the perspective of our medical staff is on this, and it may be useful to query our medical staff as far as how they would respond. How many of them are going to stay in practice? How many of them are going to have a practice which is economically feasible when their malpractice premiums triple or quadruple? How many are going to change whether they're going to prescribe narcotics? What are your thoughts on this, Dr. Lenny?
I mean, we just discussed at last month's meeting about solo practitioners and a lot of the financial demands that currently exist without Proposition 46. So I can only imagine that the financial burdens of a proposition like this would put a lot of solo practitioners or very small groups out of business. And it's ironic that the whole reason we have the Affordable Care Act, known as Obamacare, is because of financial pressures and the increasing cost of health care. And now we're potentially burdened with the proposition that's just going to increase the cost of health care further. So, I haven't queried other medical staff members, but we have spoken about this micro challenge at medical staff meetings. So.
Thank you again, gentlemen. Appreciate the important report. I think we should also say that any members of the public could access some of these people by calling the hospital.
They can call community relations if they want more information about the act. We'll provide them with information you've seen tonight, the pros and cons of it. I feel that the board may want to go on record at some time in the next few months on how they feel about the proposition. And according to legal counsel, you are allowed to do that. So I'd ask the board to give this some consideration for calendar in the next month or so. And it may be that the medical staff could take a vote.
If and when we do that, I think it would be very good to have good information as far as how would it affect this institution specifically. What would it do to our bottom line? What would it do to our manpower? What would it do to the patients who come to us to seek services? Because I think what people really need to understand is how is it going to impact them directly?
Drives up the cost of everything. I have enormous sympathy for the doctors that are in solo practice and small group practice, which is still the majority of our medical staff. And they have to come up with money for computers in their office. They have to learn ICD-10, and that's a daunting prospect. They are having rack audits now if the Medicare CMS department doesn't like how you've submitted a bill. And, for an institution like Washington to have a rack audit is hard. But for Medicare to withhold that money from a physician's office practice could mean closing the doors. So they have multiple threats out there already. What I see happening is that doctors, to deal with Medicare, will decide they won't accept Medicare assignment. And that's beginning to happen in lots of states in our country. And they just stop taking Medicare assignment and they tell the patient, this is your problem now. You deal with them. I can't. So I see some massive upheaval and enormous change coming, and not just from the Affordable Care Act, but from the changes in Medicare. And now this. It makes a doctor's life a bureaucratic living nightmare and very expensive.
Good. Again, thank you to all that have presented tonight. It's very, very informative and very helpful. Now I'd like to consider the minutes of June 11th, June 16th, June 23rd, and the June 25th of this year. I could have a motion on that.
Move for approval.
Second? Do we have a second?
Second.
All right, now we're in order. All in favor, Catherine, if you would take a roll vote on that, please.
Okay. Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Danielson,
Aye.
Director Ethan.
Aye.
Thank you. That motion passes. I'm now looking for Kent Bjornstad. Is he among us?
Right over there.
Oh, I'm sorry, Kent. How could I miss you with the hat? Kent Bjornstad will now give us a presentation.
Shifting gears to steers. That's what this talks about here. I'm Kent Bjornstad, and I had the privilege of representing Washington Hospital, all of you, at the Alameda County Fair, which was held this past couple weeks, and the Junior Livestock Auction was actually held this last Sunday, July 6th, at the Pleasanton Fairgrounds. Now, auctions always start with the top dog, or in this case, top hog. And this year, the Supreme Champion Market hog was shown by a young individual named Ross. Now, Ross is 11 years old and has a love for showing his livestock that is really quite contagious. Now, this year, when he found out that the judges had named his pig the Supreme Champion, he went around the ring, high-fiving the judges and just bubbling up with excitement. Now, this award is very deserved, as Ross feeds, cares, and walks his hogs twice a day, all while being legally blind. The inspired auction continued, and in the course of the day, in addition to Ross's market hog, 6 additional market hogs and 3 market lambs were purchased, making a total of 10 livestock for Washington Hospital. And I'm just going to let you look at the pictures and take a look at what we've purchased here. And now, just so you guys know, these kids market these livestock to a bunch of people, but they always write to Nancy and the hospital here. And this particular girl always sets up an appointment and meets with, she's been meeting with me, and her father actually lives right here in Newark in our district. And looked like a nice hog to me, so that was that one. Now, Bonnie Crawford, we bought her pig. And, you know, the kids give you a little gift when you're all said and done, thanking you for purchasing their animal. And we always donate that to the WIA, our hospital organization here, for employees. And some of the things that we got donated were gift cards to, you know, Safeway, to BJ's, to Starbucks, etc. But Bonnie did a kind of interesting thing. She, you know, when you buy feed, I don't know, I've got chickens, so I kind of know, there's these kind of, used to use gunny sacks, but now they're kind of a plastic container. And instead of throwing away, which I've been doing, she thought of a very green idea and actually cut it all up and put handles on it and sewed it back together and made a reusable bag for carrying things. So I just thought that was learning something new every day. That was great. Some of these kids here from Sunol. And again, they've all written great letters and shown great pictures, and some of these people, their moms are here working as a nurse, or dads, and they're letting us know that they've been working hard on their lambs. Tim actually got the top breeder award for the entire show too. So some really top animals. And in closing, I gotta share a few things that I've learned working on this event with Nancy over the past few years. One, I've learned that the Alameda County Fair and the Junior Livestock Auction, top shelf. Great event. I've learned that scratching your head during an auction can get you a nice market hog. Those auctioneers, they know when to get you. I also learned that, one market hog can get you 56 nice pork loins. I didn't know that till this. I've learned that 4-H stands for head, heart, hand, and health. I've learned that kids are inspiring, and I've learned that Washington Hospital makes a difference for these kids. Thank you.
Thank you, Kent. It's always a pleasure to get your report from the livestock auction. A number of years ago, the kids from the 4-H came here and gave a little presentation. And I have never seen such a good-looking, fine, really good people as those kids that raise livestock for the fair. Wonderful, wonderful kids. I'm glad we can support them and invite people to come to the hospital and enjoy the food. I see no other oral communications. We'll now move to our written communications from Dr. Lundy, our Chief of Staff.
So I have the June credentialing action items from the medical staff. We have a number of new appointments. Dr. Preet Banot, OBGYN. Dr. Ritesh Jha, gastroenterology. Dr. James McGuire, neonatology. Dr. Sylvia Molatoris, infectious disease. Dr. Elisa Monticelli, pediatrics. Dr. Jack Rose, neurology. Dr. Yao Sun, neonatology. Dr. Randeep Thiara, emergency medicine. Dr. Eko Walter, internal medicine. And Dr. Sean Wang, otolaryngology, otherwise known as ENT. For reappointments, the following list are 2-year reappointment recommendations. Dr. Farid Asfour, infectious disease. Dr. Robert Becker, anesthesia. Dr. David Bell, orthopedic surgery. Dr. Barbara Boyer, family medicine. Dr. Eldon Eichbaum, neurosurgery. Dr. Leif Erickson, emergency medicine. Dr. Marietta Fry, pediatrician. Dr. Gabriel Herskew, vascular surgery. Dr. Helen Ho, internal medicine. Dr. Lee Kwok Kong, infectious disease. Dr. Sandeep Kunwar, neurosurgery. Dr. Jay Lee, internal medicine. Dr. Sang Lee, thoracic surgery. Dr. Victoria Leapart, OBGYN. Dr. Jeffrey Lenchner, emergency medicine. Dr. Robert McCabe, infectious disease. Dr. Donna McMillan, pediatrics. Dr. Ricardo Navarro, anesthesia. Dr. Hemant Patel, internal medicine. Dr. Allison Robbins, pediatrician. Dr. Elizabeth Traynor, pathology. Dr. Dennis Unson, pediatrics. And Dr. Romy Yoon, anesthesia. We have 5 transfers in staff category. Dr. Farid Asfour from infectious disease is going from courtesy to active. Dr. Marietta Fry, pediatrician, is going from active to ambulatory. Dr. Lee Kwok Kong, infectious disease, is going from courtesy to active. Dr. Sang Lee, thoracic surgery, is going from active to courtesy. and Dr. Robert McCabe, infectious disease, is going from courtesy to active. Completion of proctorship and advancement in staff category. We have one physician assistant, Joelle Whalen, who's completed proctorship. And we have two new privilege requests from two of our radiologists, Dr. Bruce Nixon and Dr. Sunil Upender, who are getting moderate sedation privileges and have qualified for that. And we have two resignations, three resignations. Dr. Michael Klein, radiology, who's resigning because he's relocating. Dr. Victoria Shimotsu, who is a family medicine physician, is no longer in the area and is relocated as well. And Nya Lai, a physician assistant who is not going to be doing any inpatient activity anymore.
Thank you. I have a motion on that.
So moved.
We need a second.
Second.
We have a motion and a second. Catherine, if you take the roll. Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
That motion passes. We'd like now to have our Service League report. Gail, appreciate your report.
Okay. Every year we ask renewal applications from scholarships awarded in previous years. We ask them to update us on their current goal and student status. And I'd like to share with you what one student wrote. I'm currently still enrolled in St. Louis University's Medical Scholars Program, pursuing a BS in biology. After my first year at this university, I am in good standing and on the dean's list with a 4.0 GPA. As for my interests in a health-related field, I am more passionate than ever to become a physician and to continue on the medical path. In fact, due to the structure of this medical program, I will be applying to St. Louis University's medical school this coming spring. If accepted, I will know my status in their medical school by the start of my junior year. If rejected, I wish to continue my passion in medicine by taking the traditional medical school route. In conclusion, I would like to thank all of you for your support and faith in my ability. I will do my best in my upcoming medical application and interview. And this is David Chung. I was impressed with his passion and determination. What about former scholarship winners? Did they achieve their goals? I went back 10 years to two scholars who had goals to become physicians, and both of them have received their or achieved their goals. Lisa Hesaw, who that year graduated from Stanford, went on to medical school, and is now starting her residency in Santa Clara, Kaiser. Afram Bashra is a physician in Michigan. I tried to find the people from 1994, 20 years ago, but wasn't able to contact them, so I went back 30 years. And one of the applicants is now the chief of surgery at Mills Peninsula Hospital. So these scholarship winners have been achieving their goals. The Washington Hospital and the Service League have also benefit from these scholarship winners. One of our if you look at our recruitment is a picture of John Mena. He became a volunteer at Washington Hospital because he wanted to pay back the Service League after awarding his daughter a 4-year scholarship. He's been a volunteer now for 22 years. His daughter, Teresa, when I contacted her, said, you know, this award was awarded a long time ago. She said, but I am still thankful. And she's a registered dietitian in San Diego. So what I would like to do is invite any other scholarship winners, if they're around, to let us know what they have been doing, and please drop us a line. That's it.
Thank you, Gail. That's exciting kind of news to hear. It's
Yeah.
always fun to hear kids excelling and achieving goals. And Sounds like you do a pretty good job of identifying the good ones.
Well, it's funny because, if they put down that they became physicians, it was really easy to find them on Google. Because even in 1981, one of the scholarship winners wanted to become a dentist, and when I Googled his name, he is now in practice in San Diego, so.
How wonderful.
Just like you.
That's right, nothing like being a dentist. Dr. Lunny, if we could have the medical staff report.
Okay. Current medical staff comprises 509 members. 486 are physicians, dentists, and podiatrists. 23 are allied health professionals. We have 323 in active status, 58 provisional status, 66 ambulatory status, 33 courtesy status, 3 consulting status, 3 administrative. And we currently have 48 applications in process. Both the majority are have full applications. I think we have 3 or 4 with pre-applications.
Good, thank you. Thank you. We'd like now to move to our hospital calendar. Nancy, if you could present that.
Go
for
ahead,
us.
Joe, please.
Past health promotions and outreach events. On Thursday, June 19th, Christy Caracappa, Health Insurance Information Service Coordinator, presented on Medicare to the Seniors in Retirement, SIRS Group, at the Newark Pavilion. 90 people attended. On Saturday, June 21st, Washington Hospital participated in the Tropics Senior Health and Resource Fair in Union City. Lori Roffelson, registered dietitian, presented information on nutrition and diabetes. 180 people attended. Upcoming health promotions and community outreach events. The 2014 Central Park Summer Concert Series kicks off on Thursday, July 10th. Washington Hospital is the co-presenting sponsor. All concerts are held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. and are free and open to the public. Washington Hospital will be providing health information and health screenings during the 6-week concert series. On July 19th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute will host the 7th Bay Area Symposium on Advances in Neurosciences. World-class neurologists, neurosurgeons, radiation oncologists, and other healthcare professionals will be speaking at the symposium. Nationally and internationally recognized experts will discuss a wide range of topics focused on neurological diseases, disorders, and treatment approaches. The program coordinators are Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. To register, call 510-791-3417. Space is limited. The Washington Hospital Healthcare Foundation Report. On October 11th, the Washington Hospital Healthcare Foundation will host the 28th Annual Top Hat Dinner Dance. This year's gala will be co-chaired by Rod Silvera and Skip Turner, the owners of Professional Home Care Associates and Neurosport, and Dr. Jan Hensdorf, Chief Medical Information Officer at Washington Hospital. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the Washington Special Care Nursery, which is affiliated with UCSF Benioff Children's Hospital, San Francisco. This unit in the hospital cares for babies born prematurely or with life-threatening conditions. Funds from the gala will support patients' families and provide technology upgrades. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the foundation at 510-791-3428. The Washington Township Health Care District Board of Directors Report. In the past month, District Board members represented Washington Township Healthcare District at the Union City Chamber of Commerce's Spirit Awards Luncheon on June 13th, and at the Newark Chamber of Commerce's Celebrating Business Luncheon on June 19th. Washington Hospital Employee Association, WIA. we have selected a winner of the annual $2,000 Don Pickenpaw Memorial Scholarship. Caitlin Kopeski, daughter of Suzanne Kopeski in patient accounting, will attend Cal State University Fullerton in the fall, majoring in communications and business. Caitlin will receive her award on July 30th during a special reception. Also during the month of June, the Washington Hospital Employee Association donated tickets for the Oakland A's versus Boston Red Sox baseball game to families from Abode Services. Washington on Wheels WOW Mobile Health Clinic. During the month of June, the Washington on Wheels Mobile Health Clinic WOW continued to serve community members at the Fremont Senior Center, the Fremont Family Resource Center, the Silliman Activity Center in Newark, and the New Haven Adult School and the Ruggieri Senior Center in Union City. The WOW Clinic also provided health care services to the students and families at Briar Elementary School in Fremont and Schilling Elementary in Newark. Washington on Wheels kicked off the summer's free glucose screenings at the Newark Gardens, the Newark Senior Center, the Niles Canyon Mobile Home Estates, the Ruggieri Senior Center, and at all other scheduled sites. WOW provided 201 screenings in June and found 2 people that were unaware of their elevated blood glucose. They are undergoing further testing and treatment for diabetes. Visit www.whhs.com/wow or call 510-608-3203 for more information on where screenings will take place. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of June was 265. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was June's most viewed webpage with 12,682 views. InHealth, Channel 78. During the month of June, Washington Hospital's cable channel 78, InHealth, taped new programming including the June Board of Directors meeting and a Diabetes Matters program titled Healthier Hoax, Smart Food Choices. On March 26, 2014, the Congressional Subcommittee on Oversight and Investigations held a hearing entitled Where Have All the Patients Gone? Examining the Psychiatric Bed Shortage. The hearing examined the shortage of beds reserved for psychiatric patients and the strain it exerts on the seriously mentally ill throughout our communities in the form of homelessness as well as increased contact with law enforcement and the criminal justice system. While the hearing took place in Washington, D.C., it's an important issue that has a local impact. Portions of the hearing will air on InHealth with an introduction provided by Nancy Farber, Chief Executive Officer of Washington Hospital, as she helps localize the conversation about this issue to Southern Alameda County and begins to educate the residents of the district about the critical shortage of inpatient psychiatric beds and mental health resources. Other updates. Washington Hospital Healthcare System was a sponsor of the 2014 Fremont 4th of July Parade. Representing the hospital were Dan Avery, co-vice president of the Washington Hospital Employee Association, and Zohal Aslami and Giachi Luo, both members of the Washington Hospital Service League. They participated in the parade by carrying Washington Hospital banners in front of the Tri-City Band Corps. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070. You can also follow us on Facebook and Twitter.
Thank you. On July 1st, I was notified by my administrative team and security that a roller bag suitcase was found in our hospital. In that suitcase were the components consistent with components of an improvised explosive device. We don't know what the intention of the man was who brought that here to Washington Hospital. When it was discovered on the advice of the Fremont Police Department, we went to a state of heightened security, and we have placed the matter in the hands of the police department and the FBI, and we, at this point in time, are still on fairly heightened security, and we appreciate the public's willingness to cooperate with us on that, and be keeping the board apprised of progress if we happen to learn of any. But for the time being, we're remaining at that heightened state of alert. I have some wonderful news, which is that our very own Pat Danielson this morning was elected as the vice president of the Alameda County Special Districts Association. She will serve a 2-year term. We want to congratulate her on that. That's very nice for you. I'm also pleased to announce to the Board of Directors that on Tuesday, the County Board of Supervisors made provision for an $8 million grant to St. Rose Hospital. $2 million of it came from Measure A funds, from the unobligated Measure A reserve. $2 million more came from a roll-forward balance of the sobering and detoxification center allocation, obligated in Measure A, and $4 million from the remaining 2013-2014 county budget balancing designation. They're hoping to take this money and get matching money from the federal government. $2 million of the reallocated Measure A funds will be used to fund what's called an IGT, an intergovernmental transfer, that may leverage an additional $1 million in federal funding. The $6 million from Measure A and the county budget balancing designation has the potential to leverage an additional $6 million in federal matching funds, contingent on negotiations which have yet to occur. If all of the levering potential is realized, the total for 2014-2015 funding generated for St. Rose Hospital could be as much as $15 million. I wanted to make sure that the board was aware of that. Also, in the last day or so, Moody's Investors Service affirmed that the Sacramento, California-based Sutter Health A3 revenue bond rating and revised its outlook to negative from stable. The affirmation that Sutter Health's bond rating was based on a number of factors, such as its history of strong cash flow production and its conservative asset liability structure. The negative outlook reflects changes in Sutter Health that they're currently facing, including its poor performance in fiscal year 2013 and a capital plan of over $5 billion over the next 5 years. And when we touched on this self-same issue, when we discussed our upcoming budget, we met on the 11th of June, at the very self-same time that reimbursement is being cut back radically, California hospitals have huge financial commitments in construction. And it's kind of like coming at the wrong time, and what's happening to Sutter is what's happening to everybody else. They posted a $22 million loss from operations in fiscal 2013, which compares to an operating profit of $549 million in the preceding year. Mentioned earlier today was a lawsuit that's been filed against Blue Cross. It was preceded by another lawsuit that was filed against Blue Shield in state court, accusing the company of misrepresenting that their policies would cover the full network. The lawsuit that was filed today against Anthem, actually it was filed on Tuesday. Anthem's being accused of misrepresenting the size of its physician networks and the insurance benefits that were actually going to be provided. Also, California regulators are investigating whether Anthem and Blue Shield of California violated state law in connection with inaccurate provider lists, making it difficult for patients to obtain timely care. We have all of that going on. The end of June, the Department of Public Health conducted a combined MQSA certification and state accreditation inspection of our facility's mammography program. The federal inspection was performed to verify compliance with the provisions of the Mammography Quality Standards Act, and as a result of that inspection, a separate report was generated from the notice that we received from CDPH. The state inspection was conducted to ensure compliance with the provisions of Title 17, the California Code of Regulations, the California Health and Safety Code, and we are pleased to report there are no items of non-compliance that we have passed without any deficiencies whatsoever. And finally, I'm pleased to introduce you to our Employee of the Month, Kathy Berry. There she is. She began her employment with Washington Hospital in 1989. She has seen the Human Resource Department grow and change as the department went from a paper-driven department to a 21st century online department. During her 24-plus year tenure at our hospital, she's worked in a variety of areas of human resources, such as employment, recruitment, the employee selection, contract interpretation, compensation, and HRIS. Now she works mostly in employment and has been described by her customers as a subject matter expert in the area of contract interpretation as it relates to selecting internal candidates for open and posted positions. She's always willing to help managers to quickly get employees on board, and while the onboard process sounds simple, Kathy ensures that each and every new hire completes their background check, completes their licensure check, their new hire physical, and completes all new hire paperwork and attends orientation. And she makes sure that all the new employees show up to work on the first day of employment so that her customers, who are the managers, are happy. And if that's not enough, each of her reviews has emphatically stated how happy the management staff is to have Kathy with us. Kathy has never been late to work and has not missed a single day within the last 5 years. Perfect attendance. In her spare time, she does like to read, travel, and hang out with her longtime girlfriends and spend time with her beautiful family, which consists of her husband, her daughter, her son-in-law, and her 2-year-old grandson, whom she describes as her pride and joy. So I want to thank Kathy for doing a job well done. Very proud to have her as our Employee of the Month.
Thank you, Nancy. I would like now to have our construction report from Ed Fayen.
Thank you, Dr. Stewart. So I'm going to give you an update on the garage today. So the parking garage went to the Planning Commission of the City of Fremont the second week of June with a recommendation from the planning staff of the City of Fremont that the garage get approved. And to, I think, there and on our surprise, what ensued was a conversation about the garage and its perceived importance as an entry point to the City of Fremont for BART riders. And there was a request from the Planning Commission that we do something to change what they described as sort of the monolithic structure that is presented to BART riders as they come off the train. So they gave a approval with the proviso that the hospital and the planning staff come to an agreement on something to enhance the look at the garage for people coming on. So we've had 3 meetings with the planning staff since then, and we've come to an agreement, I think, in concept with things that are basically changing what was some concrete panels or siding on the garage, that on the portion of the garage that faces the BART station, to change those to metal panels and to create some open space in one section of the garage, so it has a different look other than a concrete parking garage. The rest of the garage, the other 3 sides of the garage, are all maintained as designed and will have a look that's consistent with the rest of the campus. And the changes that were recommended or that we've agreed to basically are not going to be any kind of increase in cost for the garage. So that's where we stand right now. At the same time that since we anticipated approval, since we knew we had been working with the planning staff for about 6 months on this project, and we anticipated approval, we went out to bid in mid-June on the garage, and we anticipate bids coming in on Monday. And then by next open session, we should have a recommendation for you. There obviously will be some changes to that because of the change in panels, but again, it should not be for any kind of increase in the cost of the garage. So that's where we stand right now. We anticipate moving forward and coming back to you next month with a recommendation to move forward. You know that about a year ago, we put out the bid, the general contractor for a best value selection, and Vance Brown was selected as the general contractor. So what's gone out to bid is all the subcontract work that would go into the garage, and that's currently what we will receive next week and then evaluate and hopefully come forward with, at the beginning of next month with a recommendation. So that's my report for today. Can I take any questions?
I don't believe there are any questions. Thank you, Ed.
Thank you. Oh, thank you for reminding me. So in addition to that, last night, the heliport needs a variety of permits, including FAA permits, Caltrans permits, and one of the Caltrans permits requires that we get approval from the Fremont City Council for a use permit. So that went last night to the City Council, and it was approved. And so that's one of many permits that we have to get through, but those are the 2 approvals that we need to get through the City of Fremont, the Planning Commission, that use permit. And so and they announced yesterday that the city and the hospital had come to an agreement in concept, because there were city council members that reiterated the same thing that came up in the Planning Commission about they wanted a better appearance, or more exciting, interesting appearance coming off the train. So that was announced last night that we have agreement in concept. They approved the use permit without any conditions.
Great. I think we just need to make it clear to the public on that the heliport is on the roof of the
garage.
Of the garage.
Yes.
Be an exciting thing to. That ought to, that'll look good in entrance to Fremont with a helicopter landing there as Bart's coming in.
I would agree.
That's what I was thinking.
Yeah, I think that's exciting. Anyway, thank you very much,
Thank you.
Ed. We'd like now to have our quality report from Mary Boron. Mary?
Good evening, thank you. We've recently, in the quality department, been doing a lot of work around hand hygiene and trying to improve overall compliance for hand hygiene and education. And so we wanted to let the board and community know the results of that program. In general, across the nation, there's been a renewed focus on hand hygiene because the most common mode of transmission for pathogens is typically by your hands. People touch their face all day, they touch the environment, and spread infection typically through their hands. And the other side of that is that by washing our hands, we can have an action in having it be the single most effective means for preventing the spread of infection. That's infections that are acquired in the hospital and out in the community. There's loads of literature and evidence that proves that good hand hygiene can reduce these rates of hospital-associated infections and community-associated infections. On average, there's about 90,000 deaths a year associated with healthcare-associated infections, and many confounding affecting things that affect those with patients, like your current living conditions, chronic illness, seasonal conditions such as during influenza season. All of these things in addition to what we've really seen a lot of in the last 10 years is an increase in the spread of antimicrobial resistance. So that's your multiple drug resistant organisms that are really on the rise and can't be treated very well with antibiotics. And in addition, unfortunately, there aren't a lot of antibiotics being discovered or being researched out there. So that's not something that, you know, we have on the horizon coming through. So that's why we're going back to the basics of really looking at the role of hand hygiene and what it can do to help us to reduce the spread of infections. Give you some background on hand hygiene as far as the perspective of Joint Commission goes. They recognized in around the early 2000s, it was 2003, that the national average for hand hygiene compliance was about 50%. This is typically done through a lot of literature that's obtained through direct observation of healthcare providers. There's lots of literature from many hospitals across the nation that proves this. So in response to that, they decided to make it a national patient safety goal in 2003. So from our perspective here at Washington Hospital, we've always had a focus on hand hygiene. It's always been an institutional priority to make sure that we're accomplishing it. We've always had policies and procedures around hand hygiene. It's typically had the elements of being reported and monitored through our patient safety committee. Infection prevention's played a role in hand hygiene, and compliance. We analyze our data monthly. It goes from patient safety committee all the way through the entire organization and right up to the board on our current compliance rates. And it comes here on a quarterly basis that we look at the hand hygiene data, but patient safety is looking at this monthly. Earlier this year, we decided that we wanted to take an extra opportunity to really drill down on this and make improvements on our hand hygiene compliance because we're just in the struggle that most hospitals are in, where, you know, this is a constant working effort trying to improve this. So in in January, the Patient Safety Committee said, okay, what should be our goal for this year? What's our primary focus? And we decided it would be hand hygiene, and that based on that, what tools were out there to help us implement a good hand hygiene focus. And that came through looking at our Joint Commission Targeted Solutions tool. So we began to implement that in April of this year, and it's a hospital-wide program. The Joint Commission implemented it in 2010. They had looked at a couple ways with Lean Six Sigma methodology, and they wanted to also make sure that this program was evidence-based methods that achieve strong and sustained goals. Because what typically happens in hand hygiene is in a hospital, you'll see somebody, you know, puts a lot of attention around a program, compliance increases for 2 to 3 months, and then the sustainability is very difficult. So Joint Commission created their own really standardized program for how they could help hospitals sort of in this challenge. They worked in the beginning with 8 hospitals, and they're currently up to 20 hospitals, and this is actually 21 now because we joined in this year. The way to summarize the program is really in their acronym HANDS. The first part is H with a habit, creating a habit that every healthcare worker in the hospital gels in and gels out. So you wash your hands when you come in and you wash your hands when you leave. Regardless of what your intention is when you go in that room, you need to be washing your hands as soon as you enter the room and then anytime you exit. The second piece that Joint Commission has found through their research is active feedback is very important. So you engage the staff, you communicate, you celebrate improvements, and do education. The next piece, the N, I think is really essential. No one is excused. The patient is the first priority here. So it doesn't matter what discipline you are, you have to do this when you enter the room. It doesn't matter, you know, what your background is or who you are. And to attach accountability and to make a commitment to discipline for people that are seen as not being compliant with their hand hygiene. It also needs the D, data-driven. This is really important. You have to be able to present standardized data that is collected appropriately and presented appropriately. And Joint Commission has actually created tools for us. They have their own database where after you go through all their training and have your observers trained, you enter in your data of your observed hand hygiene. And they put it into a database, and they can actually tell you whether or not it's statistically significant, what your problem areas are, what disciplines are typically having a lower rate of hand hygiene compliance, that sort of thing. So the data-driven is a very important piece. And then the systems, focusing on the system and not the individual. What are the systems that we currently have set up in the hospital that help us achieve hand hygiene? Like, do we have enough Pearl dispensers? Are they available? What are the barriers to that? Have we educated everybody? Have we created a system and a culture that supports us to be hand hygiene compliant? The program goals are provided also by Joint Commission, and what they ask for is that you implement a wash in, watch out policy. We already had that at Washington Hospital, so that was good. We have a hand hygiene numbered memorandum that explains all of the indications for hand hygiene, how you should wash your hands, when, etc. And they also predicted this goal of improving hand hygiene compliance in 12 weeks. And when I first read this, I thought, 12 weeks? Well, I've read all this literature in hand hygiene on how hard it is to improve it at all. How can we, see a significant improvement in 12 weeks? And the chief of compliance and I actually got on the phone with Cedars-Sinai and talked to them because they have implemented this program. And they said, no, we thought the same thing, but we actually were able to achieve significant improvement within 12 weeks also. So, and I'll be discussing in a minute what we've seen with this. But the overall goal with this is that by improving the hand hygiene compliance, your outcome is going to be a decreased hospital-associated infection rate. So if you have more people washing their hands appropriately, as indicated, typically that's the intervention that will decrease your HAIs like C. diff, MRSA, even seasonal influenza, these sort of things. So that's the outcome way that they measure the effectiveness of the program. Joint Commission asks for a goal of 90%, and we've had strong executive leadership support for this program, and our CEO has initiated that we actually exceed that goal at 100% compliance for all healthcare personnel to improve patient safety and really provide the best quality care. So we're actually striving above what Joint Commission is asking for at this point. The components are that when you send people out into the organization to get direct observations for hand hygiene, what you really want to do is take that data back and do a root cause analysis. You want to look at what are the causes that people didn't wash their hands. And we perform those root cause analysis a lot by dialogue that we have with healthcare providers that aren't washing their hands, by looking at, did they have the Pearl dispenser available? Were they interrupted? These sort of things. We like to look back and keep on asking why did they not wash their hands? And we look at those answers. And as I mentioned before, it's very important that you perform an accurate assessment of the hand hygiene practices. It needs to be a standardized approach. There are certain ways that we define what is a hand hygiene observation. For example, if we have a hand hygiene observer who is walking past the patient room and sees a healthcare provider in the room, we are never going to look at that as an observation because we didn't see them enter. So obviously we can't, say what happened with their behavior. That doesn't count as an encounter. But if you're standing outside and you see somebody walk in directly and they haven't washed their hands, then that's appropriate because you had the direct observation that they did not wash their hands, and you could provide feedback at that point in real time. Training and educational and interactive tools are another piece of this program. Joint Commission provided a lot of training tools that we were able to give our observers and use in staffing meetings, and patient safety has reviewed those tools also. And targeted organizational specific goals. They actually have a charter for this, and we were able to identify goals, and one of them was to that this will be a part of reducing C. diff, reducing MRSA, the outcomes I mentioned earlier. So typically, through all of the pilot programs that Joint Commission participated with, this is a list of what they found ends up making people not compliant with hand hygiene. As I mentioned before, where your dispensers are placed is very important. Are sinks available in seated patient rooms? Can people easily get to a sink and wash their hands? The data being collected inconsistently and reported, on a regular basis is very important. Lack of accountability is typically a reason for non-compliance. If the healthcare worker perceives that there isn't going to be any consequence to this, they tend to have behavior that leans more towards non-compliance than compliance. That's a key factor in this. Letting people know that they will be held accountable if they don't wash their hands. Safety of culture that is not specific to hand hygiene. So this is focusing on, have you created a culture in your hospital that says that really performing hand hygiene is a safety issue, it's a patient safety issue, and creating that and making it recognized as a priority. And not educating staff could be another reason. This one with the hands full, I think, is typical, and we have seen that here a little bit, where people are collecting, like a CNA, for example, is holding things to come into a patient's room, and then it doesn't wash their hands, and so they've cited that for something for us to focus on. Gloves. When people wear gloves, there seems to be this perception of self-preservation, like, okay, I've protected myself, I have on my gloves, and that's really not an accurate perception, and so we work towards educating them about that. And then, of course, the fact that the hospital is a very busy place. People are running around trying to take care of patients, and they can forget or easily become distracted or interrupted. So those are the reasons that they gave us to focus on. But to get in more specifically to what we've done here, we created a program with a solid foundation of support behind us that came from our executive champion, which is Stephanie Williams, our associate administrator and chief nursing officer. One of the things the Joint Commission made very clear is you need physician champions in this. And we have currently Dr. Achanta, our elect chief of staff, and Dr. Martin, our infectious disease consultant. Both feel very passionate about this. Both have been engaged in this from the beginning and worked with us and supported us in this process. Project leaders would be myself and Kristen Ferguson, the chief of compliance. And the subject matter experts, the people that we go to sort of talk about in the specific different scenarios that come up with hand hygiene, are Dr. Martin and our infection preventionist, Leah Estadi. Essentially what our program elements are is that we want to obtain 100% compliance, and we want to have zero tolerance for non-compliance. The way that we've been able to do that, as I mentioned before, is really having a strong commitment in leadership that's been endorsed by the CEO and board of directors, and implementing hospital-wide accountability through our employee hand hygiene pledge. Once patient safety decided this is something that they wanted to do, we created a pledge. It's very simple. It's 2 slides. We put it on HealthStream, and it states the hand hygiene policy elements, and then it states at the bottom that the employee has acknowledged that they are aware of our hand hygiene policy and that they need to follow it as they would with any other patient safety initiative. It's just as important as being careful about what medications you give or how you take care of your patients in any other way. Washing your hands has the same level of importance with that. So every employee had a deadline of taking this. We gave them 60 days to get on there and read and click, and we were able to reach 100% compliance for that. We also sent out letters to individuals. Every employee got a letter at their house reminding them the hand hygiene policy and the importance of it. And we incorporated it into every job description and added it to our 2014 performance evaluation, stating, have you been cited for not washing your hands, or what's the hand hygiene compliance rate that you have? The medical staff participation has been very supportive also. They have taken action on making physicians accountable for not washing their hands. If a physician is observed, they receive a letter, and these number of observations can affect reappointments. So we've been able to have a lot of support in that area for getting physician hand hygiene improving. Just-in-time coaching is what I mentioned earlier with when people are observed not washing their hands. We'd like to have a discussion, preferably right at that moment, if it's appropriate, about, you were seen not washing your hands. Help us figure out what you think was the barrier in that. And it's been interesting because the feedback is, things like, I was just going in, thought I was just going to go in to talk to the patient, but I ended up having having physical contact with the environment, or I was only going to go in very quickly, or I was distracted, or your dispenser maybe could be over here, but instead it's over here, and those sort of things. These are all things that we take into consideration to help improve the environment. And analysis of noncompliance is done through the Joint Commission database. Once we put it in, they give us data telling us what they think are our contributing factors, which you'll see in a minute. And the improved availability of hand hygiene equipment has been a focus here. Luckily for us, though, we, prior to starting this, had Pearl dispensers everywhere. I mean, we've, in the last 3 or 4 years, really added these. I mean, I feel like I'm constantly asking Robert in facilities to, put up and get more Pearl dispensers, and we've really, in the last couple of years, not had an issue with this. They are everywhere in the hospital. So that didn't turn up to be quite an issue for us. And community education and keeping the community aware of how important it is to wash your hands and when to wash your hands is really of importance, because if you can decrease the rate of community illness, that also helps decrease the rate of hospital-associated infections. I wanted to go over some definitions for the methodologies really quick. Hand hygiene, I think everybody understands, is cleansing your hands with either an alcohol-based foam or gel and having friction for 15 minutes. And again, that's in our policy. It's important to define what the healthcare personnel is that I've been referring to. This is all paid and unpaid persons working in the healthcare setting with the potential to come in contact with the patient or the environment that the patient is. So this is pretty much everybody in clinical areas. This is everybody from a volunteer to physicians to nurses. The just-in-time coaches that I mentioned that interact and sort of help educate staff about when to wash your hands and what the barriers were are sometimes referred to as JIT coaches. They actively intervene for noncompliance. The data collectors are data collectors that are going throughout the hospital. They are not trained at the just-in-time coach level, so they are unidentified individuals that we have throughout the hospital every single day collecting hand hygiene data and reporting it back to the Chief of Compliance and myself. We currently have 8. We like to rotate them through the training program. Each trainer has to watch the Joint Commission training video. It's an hour. It shows you different scenarios for hand hygiene and different scenarios in the hospital for what's compliant and what's considered not compliant. Each person has to complete a scenario-based test that at a 90% rate before they can go out and start doing any hand hygiene observations. Because creating standardized training was very important to making sure that the data was valid. Where do we collect this? We collect it in patient care areas. And a patient care area is defined as any patient room, curtain floor lines, like in critical care, any of those with the curtain and floor lines, where washing would be expected. And we include all patient care areas, even hallways, restrooms, treatment rooms. So it's basically a great deal of the hospital, probably 80% of the hospital. There are exceptions that Joint Commission says you just have to recognize that there are certain times when you cannot expect hand hygiene to occur. And they've listed them. Any emergent, urgent situation in a patient care area. This is, for example, if a code is occurring. You don't want to collect data on that. You want to let people go in and make that the number one priority, of course, being the patient. And hand hygiene post-arrival in patient rooms while carrying an item. I think this is kind of what I mentioned earlier. When people you're seeing them after they've arrived in the room, you can't count that. And re-entering a patient care area within 30 seconds of performing hand hygiene without contacting anything. I mean, that makes sense. If somebody just went out and came back in, they've only been gone for 30 seconds, we're obviously not going to ding them for poor hand hygiene compliance. The last one, physical occupational therapist touching a patient while helping them ambulate to enter and exit, at entry and exit. There is a lot of debate sort of about this because PTs and OTs have much contact with patients. And so to recognize that while they're ambulating them, you can't expect them to, every time they let go of the patient or whatever, to wash their hands and wash their hands again. Then what we like to look for is just that mainly when they enter the room, they wash their hands, and then when they're done with their patient care on exit. So that discipline is walked a little bit differently. Just to run through the timeline really quickly, as I mentioned, we started this in April 15. We did get a baseline measurement prior to doing any interventions. We started doing our just-in-time coaching in May 15th. Right now, we're in the ongoing measurement phase. We have implemented some solutions. As I mentioned before, a lot of them are associated with accountability, which is well known to be one of the best interventions on improving hand hygiene compliance. We're going to be moving towards, and have already started, a little bit of sustaining goals. So here's our data on what we've been able to accomplish so far. We started off at, roughly a 59% baseline compliance rate, so we're a little above the national average. But what amazed me is that in a month we were able to see, double improvement in compliance compared to nationwide improvement. Currently, as we stand here, we are at a 96% compliance rate. And I can assure you that that data has been meticulously collected and looked at, and we are 6% above what even Joint Commission is expecting. So we're very happy with the success of what we've seen so far with this. 3 in 5 of the healthcare personnel's were more compliant post-intervention. So that's quite a big difference we made in behavior. And then what we will expect to see out of this is that, some improved outcomes in patients, like I mentioned earlier, the decrease in C. diff rates, MRSA rates, and that sort of thing. Our primary results do show that our intervention was associated with an improvement in hand hygiene compliance, like I showed on the previous slide. So the Joint Commission tool was able to identify some areas that they want us to focus on. When we collected the data, it came up a lot that people weren't washing their hands because they had their gloves on, and they would walk into the room, just put on their gloves. So again, they thought they were protected from it. That came up a lot in our data. It seemed that in scenarios where 2 people walked into a room, whether it be they were distracted or they were talking or whatever, that came up as a lot when people enter the room at the same time, not washing their hands. One thing that I was actually pleased to see in our data is that we did not have a specific type of healthcare personnel that was found to be less compliant than others. So this is actually, this data is run through our biostatistician even after we get it out of Joint Commission. And what you typically find in a lot of hospitals is one discipline wants to blame another, that says, oh, it's doctors who don't wash their hands, oh, it's nurses who don't wash their hands. We have not seen that in our data. And so we're sort of all in this together. Nobody's worse than anybody else. And we don't have that issue here with a certain discipline. So right now, we're moving towards thinking, what are we going to do to sustain this program? And we really want to make this a priority of staying at the 98% compliance. So we're going to continue to maintain and measure performance over time. We are going to continue to give feedback to managers. We get this data back to them as soon as possible. I usually get hand hygiene data every day at the end of the day, and try to get it to the managers as soon as possible. We do need to continue to train additional observers. We do not want to see a Hawthorne effect where these observers become recognized by the staff and people wash their hands because they know that who's doing the observation. So you do have to rotate these people through and train them. We'll always be focused on that. It's very important to continue to share the data and to do the staff education. That's never something we're going to be able to back off on. It's going to have to continue to be constantly. And continue to encourage patient feedback on their involvement in hand hygiene, which I'm going to talk about in a minute. And then to make sure that our community is involved, because again, it's even outside of the hospital so important that everybody performs hand hygiene so they can stay well and their families can stay well. So how can the patient help us in this program? There's a lot of campaigns that have been done nationwide called Please Ask campaign, which is basically a campaign that we've implemented here for years that we want to always be reminding patients that not to be afraid to ask their caregiver if they have washed their hands. And that's something that we really want to remind the community of again. At this point here, we're asking each other. We have nurses asking physicians to wash their hands, physicians asking nurses. It's coming across all disciplines. Patients, we want to feel very comfortable when they're here about asking the staff, hey, have you washed your hands? Sorry, when you came in, I didn't see you wash your hands. Did you wash your hands? Or they go to do something and asking them. And typically, when you do that, hand hygiene really improves. When a patient comes back and asks the healthcare practitioner, did you wash your hands? It's really heightens the awareness, and they do this. And it doesn't matter who it is, if it's a physician, a nurse, a phlebotomist, a respiratory therapist, or a pharmacist, they're expecting to be asked this. We've done and put so much attention around this that that would be something that would be very supported. So we want to continue to focus on that. And we do a lot of education for families when they're here about washing your hands right before you walk into the room and when you're leaving. We especially try to focus this on patients that are on isolation also. We have requirements that all family members here are meant to wear personal protective equipment and hand hygiene. We also have a requirement that this education, when it happens, is documented in the records so we can sort of figure out how often it's happening. And we've had very high compliance with this education. So in general, how can the community help with this? It really comes back to following hand hygiene basics. Washing your hands before you eat, after using the restroom, with coughing or sneezing, and coughing into your elbow instead of your hand. All of these things help. There's a lot of evidence that says that hand rubs and hand washing are basically just as effective. So the Perel dispensers and the alcohol dispensers that you see everybody with, those work as long as you rub your hands together and you create a lot of friction for about 15 seconds until your hands are dry. That's very effective. Hand washing, same thing, washing your hands with water and soap and rubbing them together for friction for 15 seconds and then drying with a disposable towel. And I do want to point out that in the case of C. diff, obviously, we do not advocate using hand rub. You have to wash your hands with soap and water if you have C. diff or a history of C. diff and while in the hospital. The other thing that's been really coming out in a lot of literature is that schools need to include hand hygiene in their education. And most schools are doing this with the idea behind it that if you start teaching somebody in kindergarten and first grade, to wash your hands and create a habit, you're going to typically be able to see that follow through. So the CDC is predicting and hoping that the next generation coming up will also sort of grow up with this and have better hand hygiene. Because it really boils down to the fact that the prevention is primary. That's the best way. If you make hand hygiene a part of your daily routine, you're typically going to see less infections and especially hospital-associated infections. That's it. Thank you. Any questions?
Thank you, Mary.
Thanks.
Very informative. Congratulations on the 96%.
Thank you. Yeah, we're very pleased with that.
That
Thanks.
really is a significant accomplishment.
It is, yeah. Especially it's
we
most
appreciate
higher
that.
than what they typically see in this program.
Yeah.
Yeah.
Any other board members have questions? Thank you again,
Thank you.
Mary. Time for our finance report, Chris. We'll hear from Chris Henry.
All right, tonight we will look at Washington's hospitals' results of operations for May 2014. Average daily census for May was 154.4. We'd expected 171.3 in the budget. Admissions were 19 fewer than budget at 969. Our patient days were 4,787. We'd expected 5,310 for the month. Outpatient observation equivalent days, about 145, but below what we had expected in the budget, and really below what we had been experiencing at 227. Average length of stay for May was 4.86, about 0.52 below the budget. Case mix index for May came in at 1.595. We had 159 deliveries for the month, about 5 lower than the budget. We had 339 surgical cases in May. We'd expected 381. Included in those numbers are our joint replacement cases that came in 40 below budget at 90. We did have 2 of our orthopedic surgeons out on vacation during the month, so that drove those numbers lower. Our neurosurgical cases, however, were 14 higher than budget at 28. We had 8 cardiac surgeries performed at the hospital in May. We'd expected 13. And our cath lab procedures came in 67 below budget at 350. Outpatient visits for the month came in at 7,277. We'd expected 8,908. And again, that's largely driven by lower volume in the outpatient lab area. Emergency room visits for the month were still a very busy 4,451. We expected 4,566 in the budget. A quick look at our cath lab activity again. Our peripheral vascular area drove the majority of the volume at 45%, followed by cardiac procedures at 37% in the month. A quick look at productivity. Our productive FTEs for the month came in at 1,209, about 154.3 below the budget. Non-productive FTEs for the month were 12.2 above budget at 164.8, giving us total FTEs of 1,373.8, 142.1 below the budget. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in just a bit below budget at 6.55 for May. Moving into the numbers. Total patient revenue for the month came in about 11% below budget at $162,485,000. Our contractuals for the month were high at 78.21, higher than what we had expected in the budget. And we're really seeing that being driven in Medi-Cal. And now that Medi-Cal eligibility has been expanded twice, we really are seeing that shift between our private pay buckets and our Medi-Cal buckets. For instance, Medi-Cal, prior to the expansion, would typically run somewhere between 10 and 11% of our total revenue. In May, it was 12.5%, but conversely, our private pay revenue would typically run somewhere between 3.5% and 4% of total revenue, and in May it was 1.7%. So we really are seeing that shift and dollars shifting up from the provision for bad debt and doubtful accounts up to the contractuals as a result of those folks getting coverage through Medi-Cal. So we ended up May with net operating revenue about $7.3 million below budget at $35,733,000. Operating expenses for the month came in about $7.467 million below budget at $35,730,000. We saw those variances pretty much across the board to the good. Our salaries and wages were below budget with our lower FTEs. Benefits was the exception. Benefits was slightly above budget. We did have higher health and welfare claims during the month. Supplies were lower during the month with the lower levels of activity, and as well as our purchase services and pro fees. Bad debt for the month was about $4.8 million below budget as we saw that shift up to the contractuals line. So we end the month with an operating bottom line pretty close to break even. We'd expected a small loss for May of $166,000. Non-operating income for the month came in pretty close to budget at just below $2 million. So we ended the month, and again, this is from our Governmental Accounting Standards Board presentation, which is what we use for our audit. A total bottom line for the hospital, actually about $100,000 above the budget at $1,992,000. Take a quick look at our Financial Accounting Standards Board view. This is a representation, again, to remind folks of how the financial markets might take a look at us. Operating bottom line stays the same, pretty close to break even. We pull out our property tax revenue, which finances the debt service on our general obligation bonds and our unrealized gain on investments to come up with non-operating income from a FASB point of view, about $176,000 below budget at $345,000, and a total bottom line from a FASB standpoint of about $348,000 for the hospital for May. So are there any questions on May's activity?
No questions. we proceed with the operations report.
Okay, in June, we saw 905 patient admissions, and that resulted in an average daily census of 146. It's 1.1% lower than the budget of 915 admissions and 12.8% below the budgeted average daily census of 167. Outpatient observation equivalent days of 248 were lower than budget, which was 383. That's a good number. It was 35.2% lower than the budget. Based on discharges, the average length of stay for adults and children in June was lower than budget at 4.77. This was lower than May's average length of stay of 4.86. Our budget had anticipated an average length of stay of approximately 5.5. The birthing center saw 129 deliveries in June. We had budgeted 152. Our newborns totaled 131. In surgery, we had 328 surgical cases. They were 24 cases below the budget. This included cardiac surgical cases that were 4 below budget and neurosurgical cases that were 7 above budget, and joint replacement cases that were 6 above budget. Inpatient surgical activity was below budget by 6 cases, while outpatient surgeries were below budget by 18 cases. Total surgery minutes, which drive the operating room charges, were below budget by 5,572 minutes. Inpatient surgical minutes were below budget by 4,111 surgical minutes. The outpatient surgical minutes were 1,461 minutes less than expected. The surgery center had 577 cases versus a budget of 609. For the month of June, the total number of cases seen in the cath lab were 359 versus a budget of 405. The overall cath lab volume for June last year was 392 cases, so you can see the comparison, the shrinkage in cases. Interventional radiology procedures were 32 below budget. PTCAs were 16 below budget. Cardiac catheter procedures were 4 above budget. Overall, the inpatient cath lab procedures were 54 fewer than anticipated, and the outpatient procedures were 8 more than expected. Non-emergency outpatient visits for June totaled 7,312. They were 858 lower than the budget of 8,170. The emergency room recorded a total of 4,226 patients, a daily average of 141. This was 243 visits below the budget. Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,485 patients during June, 260 less than what was budgeted. So our total system emergency room and clinic visits for June are projected to come in at 7,711 compared to a budget of 8,214. Full-time equivalents for the month of June totaled 1,380.8, which included 16 agency personnel. This was 58.3 FTEs lower than the budget. Productive FTEs per adjusted occupied bed were 5.89 in June, just slightly above the budget of 5.75. Total FTEs per adjusted occupied bed were 6.86. That includes the non-productive FTEs. Productive FTEs were below budget by 92.8 for the month. Non-productive came in at 34.5, above budget. When I looked at the agency personnel, the predominant number of them are in the IT division working on projects, and they're temporary. They won't be there on a permanent basis. Preliminary information indicates the inpatient revenue for the month of June amounted to $117 million compared to a budget estimate of $130.4 million. Of this amount, 55.8% was Medicare, including Medicare HMO, and 20.7% was Medi-Cal, including Medi-Cal HMO. So you can see a steady diet of government payers is not going to balance the books. Total government program revenue for June was 76.5% of total inpatient revenue versus a budget of 72.7%. Kind of hard to project when the state was going to be expanding the Medi-Cal roles, so it was somewhat of a guess. Total government program patient days for June were 78.3% of total inpatient days. Inpatient revenue for the month was under budget by $13.3 million, or 10.2%. This is attributable to lower census and procedure volume in the OR and the cath lab, which drove lower daily hospital service and ancillary service revenues. Outpatient revenue for June was above budget by $1.2 million. In summary, we had 10 fewer admissions and 641 fewer inpatient days than were anticipated in the budget. Surgical cases were below budget by 24. Cath lab procedures were below budget by 46. Outpatient visits for June were 10.5% below the budget. ER visits were 5.4% lower than anticipated. And clinic visits for the month came in below budget by 6.9%. The total paid FTEs were below the budget by 4.1% for the month and below the last 12 months average by 61.9 FTEs. Inpatient charges for the month were lower than budget by approximately $13.3 million. Outpatient charges were higher than budget by approximately $1.2 million. Total hospital charges for June will come in below budget by approximately $12.1 million, or a 7% negative variance. On June 30th, there were 155 days cash on hand. The total days revenue and accounts receivable at June 30th was 70.2. The days revenue and accounts receivable excluding Medi-Cal was 67. Days and accounts receivable excluding Alameda Alliance was 56.4. The situation with the Alameda Alliance is a serious issue for all of the providers. And I don't know when that's going to get straightened out. I don't think anytime soon. During the month of June, $1,786,181 of charges were approved or are pending for charity assistance.
We have a few action items tonight. Item A, these will be presented by Ms. Danielson.
Mr. President, in accordance with district law, policies, and procedures, I move for approval of the proposed pediatric surgery privileges.
Second. We have a motion and a second. Dr. Lenny, would you like to just explain that briefly for us?
Beginning a pediatric surgery program here, and our surgery department has come up with a core set of pediatric surgery privileges to get the program started.
Good. Any other discussion or question on that? Catherine, if you take the roll.
Yes. Director Stewart?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye. Thank you. That motion passes. Item B.
Mr. President, in accordance with district law, policies, and procedures, I move for the Board of Directors to confirm the Chief Executive Officer's emergency approval to initiate the purchase and installation of an additional HVAC system in the clinical lab department for an amount not to exceed $51,000. This project was not included in the fiscal year 2014-15 capital budget.
Do we have a second on that? Second. A motion and a second. Nancy, if you'd like to explain this.
There are more demands on the HVAC system in the lab than ever before, and as we've added new equipment, it warms that area up, and a lot of the equipment in there doesn't like to work when it's warm. It likes to be cool. And we reached a crisis point last week, and I authorized on an emergency basis Robert Alfieri to proceed with making the arrangements for supplementation and repair of the existing system. I think that the lab HVAC was designed in the 1970s. And it was time for them to have some dedicated support for air conditioning. It wasn't comfortable for the employees working there, and it wasn't good for the equipment that's in there. So that is a repair and supplementation that's in progress now. And I'd like the board to ratify the decision that I made under the emergency authority that I have for repairs.
Thank you. Any other discussion on that? Catherine, we're ready for a vote.
Okay, Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Dr. Danielson.
Aye.
Director Epen.
Aye.
The employees in the clinical lab, thank you. I know they do.
Yes. We've reached the end of our agenda for our open session. We'll now adjourn to a closed session. Thank you for your attendance tonight. We're reconvening to an open session. We announced that no action was taken during the closed session. There being no other action items tonight, this meeting is adjourned.